So hi everybody, I'm Kiersten. I'm a PGY2 in internal medicine over at Brown in Rhode Island. And my case is a little bit of a different flavor. We're going back to structural anatomy here. And I've entitled it Bubble Trouble. It's the first reported case of duplicate SVC with cross drainage as an etiology for paradoxical emboli. This is a brief outline, same as everybody else's, so we can skip to the introduction. So regarding duplicate SVC, even though it's very rare, it's actually the most common venous anatomy. It occurs in roughly 0.3% of the general population and an estimated 10 to 12% in patients with congenital heart disease. That's roughly every 2 to 300 patients. So I'm going to highlight some of the important considerations going forward. The case itself is that of a lovely 63-year-old female. She's got a past medical history of AFib on Coumadin. She's had prior ASD and VSD repair in her 20s. And she's presenting this time to the hospital with altered mental status, fevers, and a facial droop. And as you can see, as evidenced by the CT here, we have a right frontal brain abscess. She underwent subsequent burr aspiration. It grew mixed oral flora. And she was started on a long, prolonged course of antibiotics. The etiology of her brain abscess was not clear, and given her history of congenital heart disease, she underwent transthoracic echo with bubble. So the bubble study was grossly abnormal, and upon injection of that agitated saline, you can see in the 4-chamber view here, it illuminated the left atrium and left ventricle. So that suggests a complete right to left shunt, and we should immediately stop injecting saline at that point, as those bubbles could embolize to the brain. She had this anatomy further characterized through CT and cardiac MRI with velocity mapping, which uncovered drainage of persistent left SVC into an enlarged coronary sinus, and then also identified the shunt. So a brief background on venous anatomy. So we have our normal anatomy on the left side of the screen, and then your typical duplicate SVC drainage. You will encounter patients with typical duplicate SVC. There are a few important considerations in these patients. Namely, one, as the coronary sinus sees increased venous flow, it enlarges. It's in close proximity to the SA node. So these patients are prone to arrhythmias. Furthermore, as it balloons out, you can have real thrombus formation in there. You get coronary sinus thrombosis, and then it's also important to consider any venous anomalies in the setting of procedures, particularly line insertions, namely central lines, PICC lines, also pacemakers and everything like that. There's a lot of documentation to show a line going into the coronary sinus is associated with profound hypotension, tachyarrhythmias, cardiogenic shock, and even cardiac arrest. So to demonstrate the mechanism of cross drainage, you can see in the schematic I drew here, we still have retained from the prior slide the left SVC draining into the coronary sinus, and now you can see the shunt itself. So right SVC into the left atrium. The role of anticoagulation in this population is highly controversial and very limited, which is obvious. The observational data we do have on right to left shunts shows there is increased morbidity related to stroke complications, TIA, and cerebral abscess. So surgery, though not typically required for usual duplicate SVC patients, was recommended in this case because of the shunt. So the last important concept here is that the bubble study did identify a pattern of flow that was dependent upon which arm was injected with agitated saline. So because she happened to have a right peripheral IV in place, when saline was injected to that arm, it showed the right to left shunt, but had it been injected into the other arm, we would not have seen the abnormality. So there may be some utility going forward in checking bilateral injections in patients with known congenital heart disease, especially in ESIS, embolic strokes of unknown source or brain abscess. So in conclusion, for your patients with brain abscess, consider paradoxical emboli, especially in the setting of congenital heart disease. Recognize that you need that TTE with bubble, and that bubble studies may be limited. And be wary of your patients with duplicate SVC. Even though they're usually asymptomatic, there's potential for arrhythmia and coronary sinus thrombosis, and just be wary when you're doing those procedures on those patients. Thank you. Did you catch that? I talked really fast there.
This is a great case, and thank you for reminding us that structural heart disease is not just all about valves and holes. This is a fantastic case. What did you end up doing?
So we recommended for her for surgery, and she has declined. She's still thinking about it. She had a really prolonged recovery after the brain abscess,
Yeah.
a lot of rehabilitation.
I plugged one, put an amplatzer of the juncture of the coronary sinus, and then send one for surgery. I mean, the challenge is, do they have collaterals to the other side? And you know, the patient that ligated her SVC, she ended up with an extensive DVT because she didn't have robust collaterals to the other side. But this is a fascinating case.
Thank you. And
I may have missed it, but where was the initial infection? Where did you find the source?
So we never found the source. We never found the source. We actually did the TTE in the setting of new hypoxia. She had extensive DVTs and PEs, which prompted that workup. But it wasn't initially done in the setting of her abscess.
Great.
Thank you.